Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on Hodgkin's lymphoma. Just before we start, I want to go through a few housekeeping items. So this Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, this session will be followed up with a live Q&A session. So please keep your questions in mind and be sure to attend the Hodgkin's lymphoma Q&A afterwards. So to introduce our speaker today, we have Dr. Jaqueline Costello, who is a hematologist in St. John's, Newfoundland, and an assistant professor of medicine at Memorial University. She is a general hematologist who has an interest in treating CLL and lymphoma. So thank you, Dr. Costello, for joining us today, and you can get started as soon as you're ready.
Perfect. Thank you so much. I'm so pleased that I was asked to do this presentation today to talk about Hodgkin's lymphoma, which is a very common lymphoma that I see in my clinic. I am a hematologist in St. John's, Newfoundland. I am a general hematologist, but I have an interest in lymphoma and CLL. I do have a couple of disclosures for some advisory boards for Pfizer and BMS who have novel agents in the Hodgkin's lymphoma sphere. So today I plan to quickly sort of define Hodgkin's lymphoma and some epidemiology or some characteristics of the disease, talk about how you as the patient could potentially be worked up for your Hodgkin's disease, discuss treatment options that are available in Canada, provide some information on some up and coming advances for Hodgkin's lymphoma, and in the breakout session, answer any questions that you may have. So to go back to the basics, lymphoma is a cancer of the lymphatic cells or the immune cells. The cancer can involve the lymph nodes. Lymphoma can also have a leukemic phase where we would see involvement of the peripheral blood. And if you see the picture here on the right, like I like to tell my patients, we have lymph nodes from head to toe that helps us fight infection. So they are a vital part of our healthy body. But when one of these immune cells or one of these lymphocytes go awry, that's how we get lymphoma. Lymphoma in general is the fifth most common cancer in Canada. Hodgkin's is a little more rare. Hodgkin's only accounts for about 15% of lymphomas and less than about 1% of cancers in general. But in Canada, in 2025, it is projected that we'll see about 1,200 new cases. It's more common in men than women, and we also see sort of two life peaks. We'll see a peak of people between the ages of 15 and 35, and then again over the age of 55. That's not to say that it won't happen in those ages in between, but that is what we see typically. And as a result of fantastic advances in diagnosis and treatment, we're able to see more than 80% of patients with Hodgkin's cured. My patients, one of the first things they want to ask me is, why me? Why did this happen to me? And so the really important thing that I tell patients is nothing you could have done, nothing you could have avoided. It happens when a lymphocyte gets an abnormal change to the DNA of its cell, then that then causes it to turn into a quote lymphoma cell with uncontrolled growth of those cancerous cells. So what is Hodgkin lymphoma? Some of my patients would say to me, is that the good one or the bad one when we talk about non-Hodgkin's and Hodgkin's? And I really stop them and I say there's no such thing as a better type. And with the advances in both non-Hodgkin's and Hodgkin's, we're seeing great strides for our patients. But the thing that distinguishes Hodgkin's lymphoma from non-Hodgkin is this Reed-Sternberg cell, which in the top right picture you can see this sort of owl eye picture. And this is the cell that is the Reed-Sternberg cell. And then around as well, some, inflammation, other white blood cells, Hodgkin cells. But unlike other cancers, the cancer cell in particular is not that plentiful, as you can see in the picture down below. Whereas if you had a breast cancer or colon cancer, we would see just sheets of colon cancer cells. The thing that makes Hodgkin's particularly symptomatic is all of these inflammatory cells that go along with it. So patients will oftentimes have B symptoms, which we'll talk about in the next couple of slides. Again, going back to why me, and for the most part, in most cases, we're never able to pinpoint why Hodgkin's happened to our patients. But we know through historical information that things like Epstein-Barr virus, HIV, things that cause a weakened immune system, and even a family history can be things that can contribute to the development of Hodgkin's lymphoma. But again, the thing I really want to hit home that I tell all of my patients is there's really nothing you could have done to avoid it. So never beat yourself up about this cancer in particular. How would you feel if you developed Hodgkin's lymphoma? So you could develop swollen lymph nodes. Sometimes my patients will tell me they'll feel a little lump in the shower or when they're scratching their neck. More rare will be things like recurrent fevers, pruritus or itching that grows over time. Some of our patients could lose weight over time. Some people could have drenching sweats at night. And then some people, if they have a mass in their chest or lymph nodes around their lungs, could have a cough or a feeling of shortness of breath. The picture I have here on the right is called B symptoms. So this is again, back to the basics of the pathology of the Hodgkin slide. The B symptoms are felt in Hodgkin's patients because of that inflammatory milieu or the inflammatory cells around the Reed-Sternberg cells. So drenching sweats where your bedclothes could be soaked or saturated, losing weight without trying. In particular, we're worried about more than 10% of body weight, or recurrent low-grade fevers or even high-grade fevers, more than 37.5, that keeps coming back without any good explanation. And why that is important, I'll show you in a couple of slides, is the B symptoms will help us direct what type of treatment we may want to offer our patients. For the diagnosis of Hodgkin's, it always requires a tissue diagnosis, so it's not something that we can see on a CT or PET scan. This is Hodgkin's. It always requires tissue diagnosis. And now with the advantage of PET scans, not many patients require bone marrow biopsies, but it could be a potential. But since we have good access to PET scans, my utilization of bone marrows has gone down dramatically. Of course, so the waiting game is something that we never want as patients and healthcare professionals. But sometimes this Hodgkin's diagnosis can be a little bit tricky. So it may take a few weeks in between your biopsy and actually obtaining the results. On the right there, I have some other types of biopsies. So some patients will get a full excisional biopsy of their lymph node, a full surgery to take out the node, and that's what we prefer. But some patients can only get a core biopsy because that's what's the most accessible. And in their area, maybe there's not a surgeon or someone who can do a full excisional biopsy. And again, bone marrow biopsy very rarely is done. And pleural or peritoneal sampling would only be done if a patient had a really tricky diagnosis we couldn't sort out, and we needed to get some fluid from the body to sort out if the Hodgkin's was involved. So when I first meet a patient, the most important thing is the history and physical, and find out more about the patient's history and their medical past and things like that. But then you'll start getting some testing. That will be some blood work. You may require a heart scan called a MUGA scan or an echocardiogram. We don't do those in all patients, but certainly patients with cardiovascular risk factors. Some patients, if they're going to receive a chemotherapy called bleomycin, and if there's any risk factors, may get pulmonary function testing, which is blowing into a series of machines in order to calculate your lung volume and your lung fitness. And then if you are in anywhere proximity to a PET scanner, most of our patients would get a PET scan for staging multiple times throughout their journey. And I'll show you some slides going forward of some of the points where you may go to get a PET scan. So these are actually two of my own patients in the last few months who gave me permission. And I just wanted to show that the PET scan really helps us to distinguish how there could be limited lymph nodes versus extensive lymph nodes. And sometimes the PET scan will actually show us information that we wouldn't have gotten otherwise. So this patient here on the left has just neck and a couple of little chest things, so fairly limited. Whereas the patient on the right has stage 4 disease and it also shows bone marrow involvement, which I wouldn't have been able to know without the PET scan. The patient would have gone through a bone marrow biopsy. So the PET scan is like a CT scan with an extra nuclear medicine phase with a glucose uptake. So it takes a little bit longer than a CT scan, but it gives us a lot of really important information. For Hodgkin's lymphoma staging, you can see here the schematic. When I teach medical students and residents, I sort of tell them a little bit the Macarena dent. So you're kind of going back and forth. So stage 1 will be limited to one area. Above the diaphragm is the sort of imaginary line. Stage 2 could cross that imaginary line for the thorax through the sternum, or could be two nodal regions on the same side of the thorax and the diaphragm that is not contiguous or too far away to consider things like radiotherapy. Stage 3 would cross through that imaginary diaphragm line, and stage 4 would be involving a other organ or the bone marrow. And so Hodgkin's in particular, we get a very sort of needing the staging because it really does direct the number of treatments that you will get. I tell patients not to be discouraged. You know, even the cure rate for stage 4 Hodgkin's is incredible these days with the advances of treatment, and not to get too hung up on the stages of 1, 2, 3, 4 compared to some things like solid organ malignancies. But it's just a vital piece of information for us as hematologists to try to direct your treatment. When we look under the microscope or the pathologist look, we decide if someone has classical Hodgkin's, which is about 95% of Hodgkin's disease, or non-classical Hodgkin's. And so the non-classical Hodgkin's, I think in the next few years will be even taken out of the word of Hodgkin's and really been more into the realm of a non-Hodgkin's. But for now, we call that lymphocyte predominant. It is only about 5% of these lymphomas, and it's typically very slow growing. It does have an increased risk of recurrence, but for the most part is fairly easily to treat with multiple lines of therapy. But for what I'm going to talk about today, the bulk will be this classical Hodgkin's lymphoma. And there's four main subtypes. There's the nodular sclerosis, which it takes about 60 to 70% of those subtypes. Mixed cellularity is about a quarter of patients. And then the more rare but still easily treatable lymphocyte rich and lymphocyte deplete, both are about 5% of the total of classical Hodgkin's lymphoma. So that's sort of the kind of workup and the some of the demographics and information about Hodgkin's. Next, I'm going to turn my attention to the treatment. And when I first meet a patient, I tell them that really the art of chemotherapy and treatment of lymphomas is really a balancing act. And so most of the clinical trials that we do is to try to really improve the lymphoma cure rates for our patients while balancing the increased toxicity. So we don't want to give too much treatment or too little or add radiotherapy or other agents if we really don't need them. So it's really a balancing act based on the patient in front of us, what their comorbidities are, how their performance status is, the supports that you may have, what are your values, what do you want to accomplish with treatment, what's really important to you. So we take all of those things into account. With regards to the side effects of the medication, we really want to mitigate those and make those as low as possible. So again, we look at your medical problems, what your organ functions are, what other medications that you're on, and we're definitely not ageist, but we need to take into account that, you know, if you're 80, even though you could be fabulous and ride your bike every day, your organs are still 80. So we want to be sure that we lower the risks for you to increase your chance to cure the best that we can as a sort of individualized approach. So this is a pretty broad diagram. It's not specific at all, but what could your treatments be? So it could be anything from just steroid therapy if you are not well enough to take, you know, full systemic chemotherapy. Very rarely we would use radiation alone. Again, that would be if there was some reason that your practitioner didn't think that you would be a candidate for chemotherapy. But for the most part, our patients will have a combination of chemotherapy, maybe radiation. Then you'll see the block there on the right about stem cell transplant. That is for patients who have refractory or relapse disease, so we wouldn't offer that up front. So then what happens after the treatment? You would have regular follow-ups with your oncologist or your hematologist, and I'll talk about that in a little section I have called survivorship. So again, the staging for Hodgkin's lymphoma is important to us, and we use a risk classification to help give us the best evidence to give the best treatment that we can for our patients. So this is a fairly broad approach to that. So you'll see that I have it broken down into stage 1, 2, or 3, 4. So if you have stage 3 or 4, even with B symptoms or without B symptoms, we would treat you as advanced disease. And I'll show you some slides going forward about the treatment options. If you're stage 1 or 2, the B symptoms become very important to us. If you have no B symptoms and you have no bulk, so that means your tumor is not more than 10 centimeters, and a specific blood test called an ESR um, is below the range of 50, or if you have less than 3 sites, so you have stage 1 or 2 disease, and none of those criteria are true, we would call that favorable disease. So we may be able to increase your risk of cure with a lesser amount of treatment. But if you do have a mass more than 10 centimeters, your ESR, that's called your erythrocyte sedimentation rate, is elevated, or you have more than 3 sites involved. In our retrospective studies and some of our studies that we have, we can see that those patients may not be cured as much as the patients without those risk factors. And so we may need to give a little more treatment to increase your risk of, increase your benefit of cure. And so that's why we call that unfavorable. And the same goes for stage 1 or 2 with B symptoms, those symptoms I showed back a while ago with the weight loss, the fevers, and the sweats. Again, we would treat that as unfavorable. And that's not to, sometimes that's not the best word to for our patient. It has a negative connotation. But for hematologists, it helps us decide if less is more or if we should go for more treatment to increase your chance for cure. What does the treatment landscape look like in Canada? This is nice, sort of hot off the press. This is the Canadian Drug Association, the CDA's recent schematic, which was made by a panel of hematology experts. So the easy one is to start off at the top. That's for stage 3 or 4 Hodgkin's. That will be a combination of AVD, that will be chemotherapy that we would have used for years, with 2 novel agents. One is called brentuximab, the other one is called nivolumab. So those are both novel agents that I'll talk about shortly. So that will be the upfront treatment. Unfortunately, not all provinces are the same. And so right now, there are negotiations to get the nivolumab and AVD covered. So where you are at the time of this presentation, this may not be covered. But going forward, there should be negotiations to have this covered throughout all of the provinces. But what is approved now in, I believe, all provinces is brentuximab AVD for those patients with stage 4 disease, and many provinces are now covering for stage 3 disease as well. Then if you come down below to the next, any stage, so those will be our patients who have limited stage, with or without favorable or unfavorable. Most patients would get either ABVD with PET scan guidance, or some centers choose a more aggressive regimen called BIACOP. So that would really depend on your provider and whether they would choose between those 2 protocols based on your stage and the favorable versus unfavorable. So then I told you at the beginning, Hodgkin's is highly, highly curable, but some patients do come back with refractory or relapsed disease. What do we do then? So we can offer more chemotherapy. And if you haven't had a novel agent, so if you haven't had brentuximab or nivolumab, or pembrolizumab. At that stage, some of us may be able to get novel agents, but for the most part, if you have had one of the novel agents, you would have a chemotherapy, and it would be what we would call a salvage. Then you would go on to have an auto transplant. Um, and then after that, your provider would try to determine whether you should get brentuximab consolidation. So that means infusions of brentuximab over several months to years, and then go from there. And then if there's an additional relapse and you hadn't been exposed to those novel agents like nivolumab, pembrolizumab, or some other clinical trial, that would be an option for sure. And so that's a really, really important thing I'm going to bring up is the clinical trials. Many centers are able to provide clinical trials, even at frontline and definitely relapse refractory. I encourage you to reach out and ask your hematologist or oncologist, is there a Hodgkin's trial for you that you could be eligible for? Because it's really important to keep these clinical trials going. So what transplant eligible meant on the last slide would be, someone who's fit for very, very intense chemotherapy. And I don't want to give the criteria for that because they're different throughout every province. But if you're transplant ineligible, that means that you are not somebody who is able to withstand very tough chemotherapy, something like a salvage or an auto transplant. So what the CDA group came forward with for the ineligible patients who would not get an auto transplant would be for pretty similar, to be honest. If you're stage 3 or 4, it would be one of those novel agents, brentuximab or nivolumab, with a backbone of the AVD. And then if you had early stage, that BA-COP could be very tough for you, and so the recommendation will be ABVD with PET guidance. So if you needed to have, most patients will get 2 cycles of ABVD, then a PET scan to decide then should they have more cycles of ABVD, or at that juncture, should we do radiotherapy? Most of those drugs I talked about, if you are going to get those, obviously you're going to be in a center where you're going to have a good chemotherapy explanation. So that wasn't the point of my talk today, to go through the risks and benefits of those drugs. It was just to show sort of that hot off the press algorithm that we have through the CDA. Most of the treatment that we have for chemotherapy are administered intravenously. Some patients may request a port or a PICC line or a Hickman catheter. Some of my patients go through all the way with an IV, so it really depends on your comfort and your team and how things are going. Typically, most of these regimens are every 14 days. So there would be sort of A and B parts where you would get treatment at least every couple of weeks. Sometimes my patients have medical issues and they're finding it really tough. And every now and again, we go patient by patient that we may have to lengthen out the cycles. But for the most part, it would be about every 14 days. Then just quickly to run through some of those protocols I talked about. So ABVD, adriamycin, brentuximab, or bleomycin, vinblastine, and dacarbazine. This has been the backbone of Hodgkin's treatment for decades. For the most part, the risks are things like neuropathy, infections across the board for all chemotherapy. We worry about the bleomycin for lung toxicity, and the A is the anthracycline, and so that carries a small risk of cardiac toxicity. There is a minimal risk of other cancers. Most chemotherapies, especially our older cytotoxic and myelosuppressive drugs, do have a slightly increased risk of other cancers. And this one does also carry a low risk of infertility or issues conceiving. Brentuximab AVD, I've been using for a few years now. It also has a risk of neuropathy, and then the same infections. Luckily, the lung toxicity is much, much lower, and nothing in the realm what you would see with bleomycin. Again, a minimal risk of secondary cancers and low risk of infertility. We don't use a lot of escalated beta cop here, just a couple of times, but there's definitely an increased risk of infection there. There's definitely an increased risk of secondary cancers and an increased risk of infertility compared to ABVD. Not a whole lot, but there is an increased risk. And so that will be a protocol reserved for patients who are very fit and able to tolerate a high risk chemotherapy. And then radiotherapy, for the most part, it really depends on what organ is being radiated. Is it your lungs? Is it your salivary glands? So it really depends on where the radiation is being targeted. We've come a long way with radiotherapy over the last few decades. 40 years ago, you'd have what mantle radiotherapy, so your whole body radiated, and now their techniques are so precise that the risk of adverse events is pretty low. Secondary cancer, again, depending on what is radiated, and then cardiac disease, so risk of coronary artery disease and things like that, if it was your chest or your thyroid, or lung toxicity if your chest was radiated as well. Your radiotherapist would go over all of those risks with you before you ever got radiation. And then just quickly about the relapse refractory treatment, because thank goodness this doesn't happen very often. But for anybody who is fit after their refractory or relapsed Hodgkin's, at this juncture, we would offer a stem cell transplant if you were a good candidate. And so the whole premise of the stem cell transplant is to deliver the most amount of chemotherapy to the point of bone marrow toxicity in order to get rid of the Hodgkin's the best that we can. And the stem cells come in to sort of rescue the damaged bone marrow, and then help you regenerate your own stem cells and your own bone marrow, sort of a regrowth of your marrow. It is extremely toxic, and patients really need to be well and fit enough. We try not to be ageist again, and every province is different, but there's a sort of soft thought around the country that, 70 and under is who this is best for, but we've definitely done older patients here in this province. And so that transplant is done when the lymphoma is back under control with chemotherapy or targeted treatment. So just the last couple of slides, this is just to show brentuximab. I keep calling it novel. It's not really a novel agent anymore. So it's an antibody drug conjugate to target this anti-CD30 on a Reed-Sternberg cell. So what happens is this antibody conjugate goes in, travels down the CD30 pathway on the Reed-Sternberg cell, and then it travels to a lysosome, and then allows that toxin to get in and release, and then targets cell apoptosis or cell death. So it's been around now for more than a decade. We used to use it just for relapsed Hodgkin's. I've been using it now for a couple of years in the upfront setting for stage 4, and then just in 2025, I've been able to use it in the upfront setting. Tolerate it very well. But like I mentioned earlier, there is a risk of neuropathy and fatigue and infection. So it's still, even though it's a targeted therapy, there's still definitely some side effects associated. But I've seen great things with patients with fairly extensive stage 4 disease do very well. Next is the immune checkpoint inhibitors. So the one we're really hoping will get into the forefront of the Canadian landscape. It's already been recommended by CDA is nivolumab, which is a PD-1 inhibitor. We also have pembrolizumab. So both of those in my province and a lot of provinces are approved for later lines of relapse, things like second and third line. But we're hoping to bring nivolumab in particular to the forefront for the Canadian landscape. So what that does is it actually blocks the tumor's ability to evade the immune system through the PD-1 pathway. So that's another really exciting thing this year. In particular, we saw a lot of good evidence in 2024, 2025 for the combination of nivolumab AVD in the frontline setting, which looks great and will help the patients who we thought were maybe elderly or not fit for chemotherapy, that brentuximab AVD may not have been a great choice. Some of us will choose nivolumab AVD in a setting where we thought somebody wasn't quite well enough to get the brentuximab, because in some of those studies, it actually showed that elderly patients did quite well with the regimen. But again, it is an individual decision by your provider and yourself. Another thing I'm part of, I just wanted to hit home, is the Canadian Cancer Clinical Trials Group. So always ask about clinical trials for Hodgkin's, especially in relapse. We really want to focus on maximizing our treatment efficacy and minimizing short-term and long-term side effects. You can always look yourself. Now, Hodgkin's treaters are pretty small across the country. There's, not as many of us as there are things like lung cancer and prostate cancer. But if you want to look yourself, somewhere I always look is clinicaltrials.gov to see, is there something out there for you somewhere across even the country that may not be available in your home province, especially for things like relapse and refractory disease. I have gone to quite a few lymphoma meetings in the last year, and so two things that caught my eye in the last year was at the European Hematology Association was we're getting some new preliminary data on some of these bispecific antibodies. So instead of just targeting one part of the Hodgkin cell, it's actually able to target multiple sites. So we have these bispecific antibodies in non-Hodgkin's lymphoma, and so we're starting to see the development of these in Hodgkin's. And the really interesting thing with this BiTE, it was in combination with an allo, so natural killer cell transplant for patients. There was only 24 patients in the study, but they were heavily, heavily pre-treated, kind of at the end of what they would have been able to get. And there was actually 90% of patients responded, with half of the patients getting a complete response. So there are really, really cool things coming for Hodgkin's for the small amount of patients with refractory disease who need them. The other thing that's been really interesting the last couple of plenary sessions has been this circulating tumor DNA assessment for patients. So just a blood test to tell us if someone is in remission. Do they have a deep remission? What are the signs of their lymphomas coming back? So I see this as a really, really interesting tool in the next, hopefully, few years, where instead of relying on CT scans and PET scans to see if patients are relapsed, will we be able to do something as simple as a blood test? So this is called circulating tumor DNA, or ctDNA. So keep an eye out for this. I think this is just absolutely fascinating. And then the last couple of slides just about after treatment, which sometimes my patients, especially with Hodgkin's, because your treatment is so go, 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 you're seeing the treatment unit every couple of weeks and blood work all the time. And then it's like everything stops. And so sometimes my patients with Hodgkin's actually find it more difficult after treatment than going through treatment mentally. So survivorship, I think most people across the country where there's good access to hematologist or oncologist, after you've done your treatment, we would see you somewhere between 3 to 6 months for the first couple of years, and then every 6 to 12 months till about year 3, and then annually. We would want you to ensure that you keep things up like your annual flu vaccine or any other clinical vaccines that are indicated. Most of us would have a blood work associated with the visit, things like counseling through reproductive health with the help of obstetrics gynecology. Do you need cardiology because there's been some cardiotoxicity? So those are the types of things that we counsel in all of our visits. And then imaging, I really try to avoid. So really only if there's a significant clinical concern, or if you didn't have a complete metabolic response with your PET scan, then I may do a couple of follow-up. But for the most part, I try to avoid CTs if not necessary because of the added risk of radiation. A lot of my patients talk about chemotherapy-induced peripheral neuropathy, especially those patients who've received brentuximab and vinblastine. And unfortunately, we've not had any good studies that show us that things like those cooling gloves or constriction really help. The studies are sort of 50-50. But one thing I know that is beneficial is, healthy lifestyle, exercising, keeping your body healthy, those types of things are a good thing. Some of my patients would say to me, I know there's no good evidence. Can I just put the ice gloves on? Can I wear the constricting gloves? And in fact, I have seen patients get frostbite and damage from those. So it's really a conversation with your entire nursing, pharmacy, and hematologist oncology team of whether they think that's a good idea for you. And then what about after? So treatment for the peripheral neuropathy. For my patients, is really if they're having pain. I'm trying to help them through that. The paresthesias or the numbness and the coldness. I try not to do medications and things for that because sometimes the medication can have more side effects than the issues that the patients have themselves. But there's definitely patches and creams, lidocaine patches, capsaicin cream, gabapentin, and some of the anticonvulsant or atypical antipsychotics can help with the nerve pain. Some patients need narcotics for that. And then some of the antidepressants like duloxetine and amitriptyline can help as well. So speak to your hematologist, oncologist, pharmacy team about that. And then lastly, probably the especially my young women patients really can struggle with the after effects of things like fatigue, chemo brain, sexual dysfunction. So all of those things come back, let us know. Don't be shy to talk about those things. Things that can help are physical therapy, physiotherapy, maybe occupational therapy. Some of my patients have meditation apps and things like that. Look to your local cancer center and your societies like Lymphoma Canada, Cancer Center, Leukemia Lymphoma Society for information about that. Your local chapters may have things like Zoom groups or meetups and things like that. And for sure, healthy lifestyle, avoiding cigarette smoke, limiting alcohol, and things like exercise and things that can help with your mental health. So that's all for me today. Thank you very much for the invitation. I'm so pleased to ask. Patient advocacy is one of my favorite parts of this job. And if you do have any questions for me, I will be live. So please attend the Hodgkin's Q&A session at the end, and I can answer your questions for sure.
Thank you, Dr. Costello, for that informative presentation. Like Dr. Costello just mentioned, for the audience to have your questions answered, please be sure to attend the Hodgkin's lymphoma Q&A, which will begin in a few minutes. Thank you and see you there.